So this is a brief presentation just to express some of my ideas and use cases of how motion capture can enhance our current clinical practice. So there's this novel concept called sensory reweighting that is, in my opinion, going to be a game changer when it comes to ACL and lower extremity injury and how we rehab and get these people back to their prior level of function while simultaneously reducing their injury risk. And so the image that you see there is Dr. Dustin Grooms. He's out of Ohio State University and has done a substantial amount of work to validate what is this sensory reweighting or the changes within the CNS in the brain following ACL injury. And there's more and more evidence that is mounting that suggests that this is potentially one of the missing links that is contributing to the ongoing injury risk of individuals following ACL injury, particularly when they get back to sport. So I have a couple slides here that kind of just walks through this concept. So this is a conceptual framework for the neurological and visual motor adaptations that occur within the central nervous system after ACL. So you have the sensory neuroplasticity. So this is afferent input, that is meaning the sensory input that is otherwise disrupted. So the initial the native graft has mechanoreceptors within it that actually send important information up to the brain, telling the brain what the limb is doing in space, irrespective of any other sensory input, such as visual or otherwise. And then that gives you your proprioception, which unfortunately this is inhibited following the injury, such that the individual doesn't have good motion detection or joint positional sense is otherwise altered. And there's this depression within the somatosensory contribution to the motor control, or of how well someone moves about their limb. And then when you look at the next level, the motor neuroplasticity, this affects the altered motor output to the limb and the stability, and thus one of the proposed mechanisms of why there's subsequent re-injury. And so the motor processing requires more planning and visual feedback. That means that the individual has to better attune visually to their limb, as well as there's additional cognitive load for given motor tasks. And this leads to decreased postural control or decreased stability without visual feedback or cognitive focus on said leg and their motor patterns. And this is what we focus on predominantly within rehab, and we put them out into put the athlete back out into the open environment where they're otherwise predisposed to injury. And then the movement control, the visual feedback reliance to maintain neuromuscular control of the limb is increased, if you will. And so I'll give a brief schematic of this on the next slide. So this really just simplifies it. So you have your structural damage, the neuromuscular control adaptations, and then the depressed somatosensory motor control of the limb, increased visual as well as cognitive feedback dependency. And then we have our traditional training, that is your current standard of care on the left. And you can see that traditional training plus the utilization of vision during rehab via motor control compensations leads to more of a compensatory sensory motor control strategy. That means that the individual's brain is essentially adapting and learning how to use both visual and cognitive resources to better control the limb and to function with it. And then you if you take that individual and you put them back out into the open environment, then such as the field, the court, etc., real life, where they have to attune visually to the environmental cues and or the cognitive demands of the additional sensory input that are coming in to the system, that predisposes their knee or their limb to subsequent injury. The alternative is the adaptive plasticity. So if you have the integrated sensory and motor training, so a specific type of training where you're altering someone's visual stimulus and having them focus on external cues throughout the duration of rehab, then you actually get a more robust and a more adaptive sensory motor control strategy, such as if you alter someone's visual input via a primary example in this case would be like virtual reality or even strobe-based glasses, then the central nervous system, the brain, doesn't actually utilize or overly weight that sensory input, and thus the brain and sensory system is forced to attune to the altered sensation that is coming up from the limb and better refining it, giving it a more adaptive and a more robust strategy. So the example when they actually look at the brain in healthy controls versus those that are post ACL, you'll see this on the next slide, is that there's a stark difference in contrast in how their brain functions. So you're looking at a schematic of a topographical map of the spectrum of beta bands, or essentially brain waves, in the injured group or cohort as well as the healthy cohort. And they looked at this for alpha as well as for gamma waves as well, and it shows the same. So essentially what you can see is that during a given motor task, be it walking, jogging, or landing in this case, is that there's a stark contrast in the brain waves and the brain activity from the ACL group to the healthy group. The challenges here is that this requires advanced imaging and brain technology, sensory systems that are not clinically friendly. I'm going to show you the next slide where they do it with a functional MRI as well. So it takes it out of this more cartoon and animated state and brings it down to actually brain slices. So you can see the primary author again is Dr. Dustin Grooms and his research colleagues at Ohio State and across other academic institutions. And here you're looking at the group average that is those post ACL with increased activation during the bilateral leg press. So they put these individuals in a leg press and actually had them and looked at what their brain functionality is. And you can see the amount of increased activity relative to controls just for the simple motor task, such as doing a bilateral squat on a leg press. Okay, so where does this all come in? Is currently right now we know this is important. We know that it is increasing individuals' risks for re-injury, yet there is no means by which clinicians can succinctly identify these individuals and or demonstrate that their interventions are actually improving or enhancing the sensory reweighting. And so I actually think that by leveraging Genie Sport and Genie Health technology, that we can in fact do this. So I'll show this a couple of use case scenarios of how we can enhance this clinical identification of these patients in the coming slides. Okay, so here's a very simple motor task where you drop, the individual is going to drop from the box and land on two legs. So the significance of this is that it's a very simple motor task, one that usually patients will be safe otherwise doing. You'd obviously orient them to it first, but the key being is that when we can start to identify these individuals when we look at the amount of altered kinematics that they have in the presence of visual, a normal visual input, and then an altered visual input. And not just simply closing their eyes, but what they show is that it's actually much more robust when the individual's central nervous system and their brain has to disregard the visual input that's coming into the system, really emphasizing that it's faulty. So here's my proposal. This is just a simple example of one movement that could otherwise be done. So what they have also shown through some of these sensory reweighting interventions is the leveraging of virtual reality. So say you put this individual in a virtual space, such as even just simply using an Oculus headset, which we already have in our clinic, putting them on top of the Sears Tower or some altered environment where they're looking down and they're blinded to the ground below them. So the individual first does the test just as shown, full visual input, and then you do this again with Oculus headset, where you standardize what the individual is seeing or the environment that they're in. So again, being on top of a skyscraper, and then you have them drop and land. And you'd start with 2 legs, but then you would very quickly move on to 1 if they were otherwise competent with this. And what you'll see is that the individual that has intact sensory motor system and their brain hasn't gone through this adaptive reweighting where they use more of their visual and their cognitive demand, is that they'll be able to stick the landing, and there will be a marginal difference between the scenario in their biomechanics when they land without that virtual reality and in virtual reality. And the difference that can be picked up by this would be key biomechanical markers from the Genie Sport. And so Genie Sport would essentially start a revolution, in my opinion, on how we could start to clinically identify these individuals with the leveraging of creating an index in their movement patterns with normal visual input and without normal visual input, i.e. an artificial environment leveraging virtual reality. This is, in my opinion, something that will come to pass in time. Whether we are able to be the first in this kind of trailblazing means of starting to create standardized clinical tests and assessments that are relatively safe and simple to be able to ensure that we're really sending people back to sport or back to life with not only just retraining their mechanics and their strength, but also their brains. So here's just a more advanced task, right? So you could start even with a single leg balance, and then you would do the drop landing from the box with 2 legs, and then you would do it with a single leg, which I think would further expose the altered sensory reweighting that otherwise occurs from within the brain of those individuals post ACL. And you could have a healthy control group, and you could even look at them on their uninvolved and their involved limb. Granted, the brain is controlling both limbs, and there has been some altered sensory motor input and or mechanics that have been shown on the uninvolved limb post ACL. So we may actually need to identify healthy controls, but first, just saying, hey, is this viable? And this would be, again, an example of just scaling up the motor task that they're otherwise doing from the previous slide. Other examples would include I encourage you to try this. If you stand on 1 leg and you perform 3 vertical jumps as high as you can, and then you repeat and trying to land back in the same footprint or relative space that you left off with, and then close your eyes and repeat that. That is shown to be one of the tests that can also identify these individuals currently, but we're not using this has yet to actually be published, and nor has it been used in the presence of looking at using a clinical friendly motion capture system such as Genie Sport. So the individual will often dampen their vertical jump, so they won't jump as high. And so one of the criteria is eyes open, you take their vertical jump, eyes closed, they have to jump at least 90% as high as that, and you're looking at their lateral displacement. So often people will travel around the room or deviate off the spot from which they jumped, and particularly on their involved limb rather than their uninvolved limb. But really, I think the sky's the limit. We could get creative as we can, and I actually think that we need to be as simple and straightforward and standardized in this process, and even maybe having a battery of tests that utilize the LiDAR motion capture system in the presence of visual input and without visual input or artificial visual input would be a profound opportunity for leveraging Genie Sport, as well as the novel science that is coming out about adaptive testing for the central nervous system in the brain in this patient demographic. So the next use case is using the Genie Sport technology and visual motion capture system with a running analysis. So we actually have a very standardized approach to how we conduct a running analysis here at Stanford Healthcare. And it's developed based off the current literature, and we have actually a point system that stratifies someone's relative risk or their performance with their running analysis. And I think that Genie Sport would be a wonderful addition to how we can actually be even further objective with this. And I'll give you a very brief overview of what this analysis may otherwise look like currently. So currently we're using a slow motion capture that has 240 frames per second, and we're doing freezed frames, and we're manually drawing these in, which is, though gives us a gross estimate, I think we're all in agreement here that this is inadequate, especially given the technology that is currently available to us. And so I think that this would be a wonderful opportunity for moving forward from what is the walking gait analysis that Genie Sport has otherwise standardized, and applying it to the running analysis. And so beyond just looking at these angles, what I think would be a wonderful opportunity, if not otherwise built into this system for Genie Health, would be taking this and putting it into the framework that we've otherwise developed for our running assessment tool. And again, it is a point-based system. I'll show a brief example of this. Again, we can further conversation can go into further detail as necessary. So this is actually a couple screenshots from the Excel spreadsheet that we otherwise have. So we really try and take what is the science of like running mechanics and apply it in a very simple format and in a point-based system that patients can otherwise understand. So we have a green light, yellow light, and red light system to communicate where someone's mechanics currently are and where there is the greatest area for improvement. And so this is all essentially using Excel to create algorithms and generate this sheet for us. So the current, it's certainly a little bit labor intensive on the clinician side. Specifically, they have to not only take the video within session, but then they also have to measure in the angles. And so they put in the clinician comes in and puts in the different angles that they otherwise measure, and there's this very standardized way in which we go about this. We actually have a learning manual and even a video tutorial to educate new clinicians on the process. And so you put in the angles that you measure, and then Excel, based off the algorithms that are put in, will otherwise populate the yellow light, green light, and red light over on the subsequent column. And then this provides, it's a printout that we give to the patient, and then this provides a talking point and discussion points for the patient and for the provider, that is the therapist, to otherwise not only show areas that they're doing really well and areas for ongoing improvement, and then correlating that to the patient's potential symptoms. And so whether we use this framework or not, with the application and the marker list based system of the Genie Sport, by all means, we could certainly have further dialogue around this. But this is a framework that we use that has been relatively well received across the board, regardless of the patient patient in question and how familiar they are with running mechanics and or the granularity of looking at running video analysis. And then we also even have it down to shock absorption, so how much they're actually absorbing the impact based off the joint excursions. So we want to see something similar to this, where they have a more even means or distribution across all three joints, versus you can see on their left leg that's seemingly not the case, where they have more shock absorption going through their knee. And if this individual had knee pain, then that would make sense why we may want to potentially go through some running retraining and some alternative interventions to help bring more equal distribution across the joints. Anyways, the point being is that the Genie Health motionless or markerless based motion capture system could really help at standardizing this and bringing even further objectivity to our current running assessment platform, because currently, quite frankly, again, I think it's inadequate that we're manually drawing in these angles given the amount of human error that otherwise could cause. Another standard assessment that we consistently use is the Y balance test, and I know that Genie Health has already been in contact with the functional movement systems, and so maybe these discussions have already taken shape. But what I would where I'm really interested in a very easy use case scenario would be using the Y balance test and using the motion capture system to better analyze someone's quality of movement rather than just the quantity of movement that is otherwise performed. And I'll show you an example here on the coming slide. So currently, the Y balance test is a great tool. It allows for the clinician to stratify someone's risk of lower extremity injury based upon how far they're reaching in one direction to the next. What it doesn't account for is how someone actually gets there. And so one of the strategies that we often see following lower extremity injury is someone's inability to, or unwillingness, unconsciously, to really flex their knee. And so if I play these videos here, what you can see is though the individual reaches quite far with both limbs, regardless of the limb that she's standing on. Again, she's standing on the right in the top left, and then on the she's standing on the opposing limb in the bottom image. And what you're looking for is how much knee flexion versus hip flexion she actually uses. I'm not going to be the spoiler here, but I want you to take a guess as to which knee she's currently rehabbing from. And again, she reaches relatively similar from one limb to the next. So she, quote unquote, passes the Y balance compared to healthy controls, but the strategy at which she gets there is different. And that's where I think Genie Health would make for even a further more robust assessment by bringing in a clinically friendly video analysis. Same scenario, just reaching out in the posterior medial direction. Again, she gets quite far with both limbs, but the way at which she does that and the amount of contribution that comes from the knee is different from limb to limb. And it's these subtle altered movement patterns that make the difference between good and great rehab. It also mitigates someone's re-injury risk, not only on the involved limb, but also on the uninvolved limb. 104.5. The final use case scenario is with the hop testing. So single leg hop testing is traditionally one of the gold standards in return to sport decision making, specifically with the noise hop test, where you have the single leg hop for distance, you have the 6 meter timed hop, so how quickly they can go from point A to point B, the triple hop for distance, how far you can travel with 3 consecutive hops and then sticking the landing, and then the triple hop for distance but crossing over a 15 centimeter line. Now, there's been a lot of question and mounting evidence that suggests that these hop tests in and of themselves are inadequate because they're all in the sagittal plane, and what we actually need is more multi-directional based hop tests. And so I have a one, I think that just having a clinical friendly video analysis of these tests and starting to generate what is normative mechanics would be ideal. And would, again, just like the Y balance, would give us not just quantitative but also qualitative movement patterns, which we know are important risk factors, and being able to capture the subtleties that someone's not quite ready to return to their full capacity of unrelinquished sport. And I just want to share a couple of examples of some novel multi-directional hop tests that could potentially be used with the video analysis. Okay, so here's an example of the triple hop test, part of the noise hop test battery that I was describing, where they do three. So this is the triple crossover hop for distance. You can readily see how the motion capture system would be very valuable in being able to identify potential biomechanical markers that would be different from side to side, beyond just the quantitative distance of the individual hops. Now, what they have shown is with these forward hop tests is that up to 83% of the forward propulsion, the distance hopped, is generated by something other than the knee. Which, if we're focused around knee-based injuries, which currently a lot of our research and quality initiative improvements are, then we need more robust tests to better quantify or strategically identify ongoing risk factors. So one of the novel hop tests that I will also make a plug for is a single hop test where the individual jumps forward, lands at a distance of 70% of their height. Again, I'm still evolving with this idea and exploring it within clinic. And then they have to do a reverse hop because the quadriceps really, its main goal within sport and within biomechanics is decelerating and then re-accelerating backwards rather than forwards. And so that being able to turn on the brakes is actually, I think, a more robust and more functional means by which the quadriceps and the knee is put under stress and looking at its capacity with these individuals. And so the individual would jump forward a standardized distance relative to their height, and then they would do a single leg reverse hop, and their outcome from a quantitative measurement would be their distance hopped, as well as you could do a reactive strength index. So how long they actually spend on the ground divided by their distance hopped. That in combination with a motion capture would be a very robust physical performance test to start to identify not only asymmetries, but also to start to generate some nice normative data of where we expect people to be when returning to sport and helping clinicians to make these critical decisions. So the evidence has come to our attention that the sagittal plane hop tests are insufficient to be discriminatory enough to be able to really capture the difference between the limbs and to ensure a safe return to sport and or activity without reduction in someone's risk of re-injury. And in part, this is really due to the horizontal nature of the movements. They are really more getting a lot more contributions from the hip and the ankle, except for with the landing, which is much more quad or knee dominant. And so a novel test that has been considered and not shown with the four here would be a forward hop, a land, and then a jump backwards or a reverse hop. And they would jump forward at a certain percentage. We're looking at approximately 50% of their one rep maximum single leg hop forward. So they jump forward 50% of that, and then they jump backwards as far as they can after hitting that mark. So that is one consideration, as well as the vertical hops that have already been described in previous slides. And then here are additional plane hops that have also been described and have shown to have significantly better, almost by 20% better discriminatory properties as far as identifying individuals that are having ongoing limb symmetry deficits in their muscular power, proprioception, and overall function. And again, I think that we could even further delineate intra-limb compensations with the application of proper clinically friendly, even with markerless motion capture systems. And by intralimb, I'm really speaking to the amount of joint excursion between the major joints of the lower extremity, in particular the ankle, the knee, the hip, and the trunk. And you I guess it's up for debate as to which of the planes would be needed to be able to capture that. Usually it's the sagittal, but perhaps having a dual camera system would otherwise be necessary in order to capture the metrics or the properties that we would otherwise want. And then speaking more candidly on the whole on hop tests in general, um, with the ability to capture finite metrics with a motion capture system, it would also be worthwhile if the motion capture system potentially could capture not just the joint angles, but then also perhaps even the distance, and then even temporal components. And when we start talking about temporal components as well as distance, and then we also have a known mass of the athlete, well, then we can start to calculate power and speed and rate of force development, even irrespective of having, in the absence of ground reaction forces. And so one of the things that has also been described, particularly with the multiple hop tests, is the amount of time that the individual is spending on the ground. So though there is an energy leak or energy loss when the individual pauses temporarily in between their hops, and we're talking milliseconds, right? But they are spending more time on the ground, and they don't have that reactive strength. And that can even be calculated with the reactive strength index. And you could even do a potential modified one, a modified index in which you look at the amount of time that the foot is spent on the ground divided by or taking into account the distance that is otherwise achieved with the hops. And so I think that there's some additional granularity that could otherwise be had, considering both temporal and spatial metrics that may be able to be pulled off the video beyond just the joint angles. But hopefully this presentation and these videos give you further insight as to some of the use cases of what we're considering.